help and support and for organizing a lot of work that is behind. This is a 12 episode, and this we have a great speaker from Professor Stella Wick from UK, Dr. Lynette Lu from Singapore, Dr. Hind Khalifa from Oman, Muscat, and Professor Shannon Chan from Hong Kong. We are discussing about gender equality, and ELSA is very supportive. As you know, we have each country have a woman representative because we want the voice, but not only women, we also have a young task force. So we try to be inclusive. And I hope this episode today will bring up some hot topic and the way to move forward to be more inclusive in our society. Thank you, Sajid, and enjoy the show.
Thank you so much, Professor David Lumanto. And I think we will move on in terms of the TV channel. And the host of this episode is Dr. Lynette Lu. Hand it over to you, Dr. Lynette Lu. Thank you.
Thank you, Sajid. Hello, hi. Good morning, good afternoon, good evening, good night. Okay, to all of you. My name is Lynette Lu. I'm one of the surgeons in Singapore, and currently I'm hosting this together with Dr. Hind Khalifa from Oman. I would like to first start with welcoming all of you to this webinar, wherever you are. Thank you for spending your precious Sunday with us. And we are very honored and deeply grateful to our guests today, which are both Professor Stella Wick and Associate Professor Shannon Chan. I would like to start with introducing Professor Stella Wick. So Professor Stella Wick is one of the most influential surgical leaders in the United Kingdom. She holds dual roles as the National Medical Director for Secondary Care and National Clinical Director for Elective Care at the NHS England, whereby she shapes national policy on surgical services, waiting lists, and workforce planning. Despite that, she still maintains an active clinical practice as a consultant endovascular surgeon and a general surgeon in the Croydon University Hospital, London. As a trailblazer for women in surgery, she has been instrumental in driving systemic change to improve diversity, inclusion, and flexible training pathways within the NHS. Welcome, Prof. Wick.
Thank you. It's a pleasure to be here today.
And next, I would like to introduce Dr. Hind Khalifa. So Dr. Hind Khalifa is a consultant in the upper GI and bariatric surgery at the Royal Hospital Oman, which is one of the leading tertiary care centers in the Middle East. She serves as an adjunct governor for the ELSA Oman, whereby she plays a pivotal role in bridging surgical education across the region. Her work focuses on advancing bariatric surgery, surgical education, and empowering women surgeons in the Gulf region. She is a respected voice in the Middle Eastern surgical community and a strong advocate for regional collaboration.
Thank you, Lynette. Also, I'm having the pleasure to introduce you as well. So Dr. Lynette Lu is an adjunct assistant professor of surgery in National University Singapore. She's a sitting consultant and head of trauma in NUHS. She's a distinguished trauma surgeon and academic leader in Singapore and a head of trauma surgery in the National University Health System. She leads one of the busiest Asia trauma centers, and she is deeply involved in surgical education and a role model as a mentor to women surgeons across the world. Welcome, Lynette, as well. And from my side, I'm introducing Dr. Shannon Melissa Chan. Dr. Shannon is assistant professor upper GI and metabolic surgery. So we are colleagues, Shannon.
Yes.
She is from Chinese University of Hong Kong. Dr. Shannon is an academic leader in upper GI and metabolic surgery. And she has a clinical focus in MIS, bariatric surgery, and surgical oncology. And she represents a new generation of women surgeons and academia in the Asia as well. Welcome, Shannon.
Thank you, Hind.
Thank you, Hit. So right now we are going to be opening out our segment of discussion, and we will start with the topic of resilience and surgical journey. I would like to invite Prof. Stella Wick on her opinions and her thoughts on this topic. So, Prof. Wick, you hold two of the most demanding national leadership roles in the NHS while maintaining an active clinical practice. Can you share any specific moment in your career where you faced a barrier that forced you to fundamentally rethink how you navigate leadership as a woman in surgery? And what did you do in that moment?
So in reality, I don't think these are specific moments. I think these are continuous. And Shannon, I think I'm hoping that your reflections will show that time has changed. So I qualified in 1991. I got my consultant post in 2003, 4. And I think surgical training for women was very different. You had to dedicate your life to surgery. It was very difficult to have a family, very difficult to succeed in a man's world. But actually you worked 120, 130%. Shannon, I'm sure, Hind and Lynette, you will say the same. Women, I think, have to work harder to prove that they are equal. But I think what has happened over time, my journey has been very much to open doors to others so that they don't need to show as much resilience as we did when we were training. The numbers in surgery, of women in surgery in England still remain low. We've been working on it for 25 years. And in the 25 years, we've hardly made a difference in the number of women at consultant level. Trauma and orthopedics, Lynette, is one of the least frequented by senior consultant women. So you are an amazing role model. General surgery is better in our country. Pediatric surgery is much better. But I think the resilience conversation comes from, one, yourself. Two, it comes from others that support you. And you cannot underestimate the need for allyship, whether it's male or female around you, supporters that get you to where you want to be. But I think there is also the conversation of a work-life balance with resilience. As a woman, I've got 2 children now who are 29 and 30. I've been married for 32 years. Life is not a steady journey. There are many things that happen that knock your resilience. My parents have passed. Children become ill. You become ill yourself. I had an acoustic neuroma, needed surgery, was off work for 6 months. But actually, if you give time for resilience and realize that your resilience will go up and down, but your steady state is the people around you, and that network of supporters, family, are so important to succeed in a career in surgery. But women can do it, and it's wonderful to be with you all, showing that you can. Fabulous role models. I'm honored to be on the same stage as all of you.
So, Professor Wick, in your experience, what is the biggest reason why talented female surgeons leave training or drop out before reaching consultant level? And what concrete changes have you implemented at the NHS level to address this?
So it's a great question, Shannon. And I think our dropout rate now so it still happens. I think that's the first thing. And I think in early careers, so when our female colleagues so let me start at the very beginning. We now have 51% of women, of graduates are now women, which is wonderful. The question is, how do we bring them all the way through? So actually we have parity at consultant level. So I think in the early stages, it's important. It doesn't matter what you say. Surgery is still hard. It's physically hard. It's mentally hard. It can be distressing. If you lose a patient on table, it's distressing in a way that very few other careers in medicine are, but it's also the most wonderful career that you can have. So I think ensuring that our early year medical students and trainees who are deciding to do surgery understand that and are supported in their decision making, I think is firstly important. As we go through, again, it's the combination of role modeling. So today's program is really important. It shows women that they can. If you can see it, you can do it, is always the conversation. And then, of course, women often carry, and again, it's a privilege of having children, of being carers, and often it's carers for parents, for siblings, for children, and it's an added, and of course, the men do it as well. But there is something important about being a mother that means that you have added responsibility, household responsibilities. All those conversations happen. And I think there needs to be an understanding of that work-life balance. And what we've done in the UK, I was obviously pregnant twice. I took 12 weeks off both times with my children because there was no woman in front of me in Wales who'd had a child. So I was trying to role model. There are now fundamentals that we put into place. So if you are female and you are pregnant, you come off on call very early on, 12 to 16 weeks. I carried on to 39 weeks twice. No woman should ever do that again. Time off after having a child, you can take 6 months to 12 months. It's your choice. And there is also parental leave from the husband side as well, which is important. Conversation about going less than full time. Sometimes you need to do that and actually work maybe 3-4 days a week rather than the 5 days a week. And of course, 5 days a week as a woman means that you work 7 days a week because there are so many other things that go on. Then conversations of how we support people coming in, so women coming in and actually opening doors. So sometimes we've got jobs where we ensure that a woman gets that job because again, where the scarcity of posts, that's important. So there are lots of little things that have gone in. But the benefit for women has also benefited our men going through a surgical career pathway because it remains a tough career pathway.
So just a side talker, I just had a baby of 3 months and I just returned to work. So I might need, advice from you and Lynette and all the others before how to manage both the work and also having a family with a small baby. So in your or perhaps Lynette or I can also give some advice as a woman with a small young baby at home. How do you balance work, especially like a vascular surgeon, trauma surgeon? These are long surgeries, emergency surgeries, and you get called in like at the odd hours of the day. So how do you manage the baby's crying for mom and then you need to go back for emergencies?
Okay. Since I'm actively taking trauma course, maybe I should start first. So I still remember it's just very recent because my children are still in preschool. But yeah, when I was breastfeeding, I had to go in for trauma. I remember there was literally a time that I had to remove my baby from my breast and to go in and attend to a trauma patient that is dying. It feels heart-wrenching at that point in time. I felt like I wanted to cry because you had the hormones still flowing in you, right? But I was like, there's no way that I can let the patient die. So I'm like, okay, fine, my baby can take a bottled milk for a while, but the patient should survive. So I feel that because this is the choice that I've made, I want to honor the choice I've made. And I think that's one thing that I really wanted to tell people that actually the point is what are your priorities at that point in time and how you prioritize that, number one. And number two, is most important for me is the village that is supporting me. So sometimes we feel like is that appropriate for me to do certain things that I know I can delegate out to someone else to help me, and I don't have to be doing every single thing in the house. I can actually delegate the things that are non-essential. For example, like usual household stuff, non-child nurturing things. I just delegate it out, and in fact, that gives me a higher quality of life.
And if I may come in, Lynette, they're absolutely wonderful words, and I'm you know, and there are heart-wrenching times where you have to make decisions that I think few other careers have to make. I'm going to give you words of advice from the other side. So I say my children are now 29 and 30. One is just trust your judgment. You will never get it right 100% of the time, but it doesn't matter. I remember when I'm sure you're going through that stage now, actually, Lynette. So when the children come home from school, normally Christmas and Easter, they come home with a box full of things they've made at school, and then you go through them and you put some in the attic and the rest you throw away without them ever knowing. But my little one, the youngest one, who's now 29, Kishan, brought home it was just a yellow cutout star, and it was a Christmas star. It was a Christmas wish, and it was written on there in his handwriting, "I wish I could be a surgeon like my mother so I could see her more often." Now, that was above my desk at work for years. And when and you try and reset and work through, you know, what do I need to do? And your advice, Lynette, yes, absolutely. Anything that is not child nurturing, just, you know, if it's a cleaner, someone to do the ironing, just make sure that someone helps you, because you genuinely cannot do it all. It is really hard. I'm very lucky. I've got a sister who lived nearby, and both my in-laws and my own parents would come and help me. My husband's a surgeon, so often we swapped children in the hospital, because I was on call and then I would come off on call and he would go on call, and we would swap children literally in the hospital to make sure it worked. But all I can tell you at this point is I wrote an article, and I wrote in it that I felt I'd never been a good enough mother or a good enough surgeon. And immediately both my children talked to me and said, "Why did you write that? Because you've always been there when you were supposed to." And I think there is something about a mother's guilt, but there's also something about a father's guilt in surgery. Just understand that that guilt is there. It'll be in your heart, but actually it should be very small, because it doesn't matter, because you'll love your children and you will make it balance. But nobody can tell you what that balance is. It'll be your judgment, and it will be right. And never, ever look back to think you got it wrong.
From my side, I think new mothers should have as long leave as possible with their newborn kids, whenever that is possible, and as much help as possible. Also, I am having very, very small kids. Well, I don't have a close family support, as neither my husband's family nor my family are nearby in Muscat. They are in other cities. So I had to hire some people who help me at home. And I took addition from my annual leave as long as I could get. So I could get, like, for my two children, 4 months plus out from work. And like Lynette has mentioned, sometimes after that period, when you are called, you have to go with that guilt feeling. I think all of us would have it. We'll move to the next question to Prof. Vik. In Oman, actually, it is we have a very good representation of women in surgery. So we have a lot of newcomers, like in our residency program. We have, like, in 10 of the intake, probably 8 or 7 of them will be women currently. And we have a lot of new women consultants in surgery, on all fields of surgery. So we have a good representation of women in surgery. However, how would translate to leadership roles in education and decision making? Probably. What is your advice?
Thank you, Hind. And Hind, please do call me Stella. But again, a great question. And actually it overlaps into the question that's in the chat about how to overcome the obstacles of workplace politics. So we do work in a very dominant male culture. you know, surgery has been male for a very long time. And often they are already in roles, so they're already in education and leadership roles, and it's they who will make a difference. So I think we've got to, I'm going to use the word attack from two sides. One is we need the doors opened at senior level. So we need people to be advertising roles and making sure that they are possible for women. Women may not be able to do them full time. Many do them full time in absolute equivalence. But actually, sometimes we need to have roles that are less than full time so that women can do 2 days a week or make sure that they can support the roles. We need men to make sure that women are shortlisted. And actually, we need leadership to make sure that if there is a shortlist, that there are equal numbers of men and women if you want to drive that conversation. Or you bring the best people to the table, but you make sure that the application form pulls out the best. So women who are normally more humble don't fill in application forms in the same way, are able to be shortlisted. So I think there's a conversation at senior level. But there's also a conversation, and it's wonderful to hear your numbers, Hind, that the American women's surgical, the American women surgeons did a fabulous job, I think about 15 years ago, maybe 10 years ago. And what they did was they had mentorship programs, they had leadership development programs, they had education and leadership development programs. And what they also then did is they made sure that if any jobs came up, that there were women who were ready, who were supported to be confident, because we all have imposter syndrome, supported to be confident that they could do the roles. And they supported them by giving them early roles. So actually, when they went into a more senior role, they felt confident doing it because they'd already done part of it. So I think for us, Hind, there is senior doors open. And we need to be supporting the wonderful women that are in your program. How do you invest in them to have that leadership development?
Thank you very much, Stella. So maybe we move to a second segment of this TV program into mentorship, sponsorship, and allyship. So first, can you tell us like the difference between mentorship and sponsorship, and the importance of moving from mentorship to sponsorship, and explain like a practical example how a senior leader can actively sponsor a junior female surgeon rather than just mentoring her?
It's a wonderful question, and please, you're asking me, but ask her because you've got wonderful experience on the panel. So I think the sponsorship conversation is really important. So sponsorship in many ways, whether it's financial, whether it's mental sponsorship, whether it's ensuring that, so the Royal College of Surgeons of England, we have had an interesting problem in that in all the years that we've had a president of the Royal College of Surgeons of England, they have mostly been white men. We've had some diversity. We've had Afro-Caribbean. We've had one female white president. And the conversation was, how do we change that? So the sponsorship from the college was, we really need to understand the reasons why that is not happening. We need to change the way we elect our president. So that election of the president now is with all our members and fellows rather than with the council, which could be biased. And we've just done that now. Having done that, what's important is the best person voted by the members and fellows gets the job. And we haven't got a female president again this year, but it doesn't matter, because what we are doing is we are opening the doors at that senior level to say, this is now an open slate, anyone can apply, and women are very welcome at the table. And that is an important conversation that comes through. Mentorship is what I do every day. I mean, I sponsor lots of conversations and try and open doors as much as I can. But the mentorship conversation is important. And I would say to anyone listening on the call, if you are at a conference, at a meeting, and there's somebody you resonate with and you think, I would love to be like them, doesn't matter whether they're male or female, go up and ask that question. Please, would you be my mentor? Nobody will say no. And if they find they haven't got time, they will make sure that you are supported by someone that they know that will support you on your journey. But the mentorship conversation, and I've got several mentors. My first boss back in 1991 was Kieran Horgan, a breast surgeon. He did two things. One, he has mentored me all through my life. The second was he introduced me to my husband, who was the breast research registrar, and we got married about 4 years later. Kieran
Is that the
been...
most important thing that he did for you?
Oh
Introducing
no,
your husband.
he's done so many things. But what's wonderful is I've gone back to him for advice. I've gone back to him to say, what do you think about this role? And what's lovely, he's retired now. I still go back to him now. When I apply for a job and I get a job or don't get a job, I always drop him a WhatsApp message and say, Kieran, this is because of you. This is because you, at my very first step, when I wanted to know whether I could be a surgeon and I wasn't sure, you said to me, have a go, see what happens. What can happen? It might be that you may not get there, but if you don't have a go, you will never know whether you could have succeeded. And it's a short conversation, but it made a fundamental difference. So that mentorship and allyship is really important. But the sponsorship is where we really lift people and help them to that next stage. But I'd love to hear the conversation what others are doing as well, because you're doing great things.
For me, actually, I find mentors at different stages of my progression. I had very excellent mentors at specific time, but I don't know if everyone agrees with me. Sometimes you don't have it's very good to have a mentor all over your progression, but sometimes when you are a junior, you find a lot of mentors. But at a certain level, when you become a senior and when you need a support, you don't have that many. And that's what happened to me. I had mentors at different stages of my life. When I was a resident, I was having a very good mentor. It changes when I become a fellow. And one of the mentors who was with me during the fellowship till now, I can go back to him. And whenever and sometimes you are disappointed when you become at the same stage of qualification with the same person. People a little bit do not support you the way you want. I don't know if that has to do with personality or to gender or what, but that's what I find in my experience. Going back to Shannon, what is your experience? Have you find your sponsors being a male or a female during your progression?
I think in Hong Kong, I think it's probably the same in Singapore and also in the UK. I'm not sure about in Oman. Probably also in Oman, as I heard from you. You'd find that a lot of your mentors and sponsors are male, and they are often more supportive than you'd think they are. Because I think in this specialty of surgery, a lot of the senior consultants are male. So naturally, your mentor or sponsors have to be male. And in Hong Kong, like thinking back, I don't think as a female surgeon, it put me at any time at a disadvantage. Like at all times, we work equally and we pay the same effort, and at the end, we get the same opportunity. And my mentor and also sponsors currently was my boss, and after they retire or they left for other jobs, they actually promoted me to be the head of upper GI surgery as a very young surgeon. And I think it's very generous of them, and they constantly are thinking of how to uphold and how to promote younger surgeons, not particularly female, but younger surgeons to take over and to take over the leadership role, and they see the opportunities equally. So I think in Hong Kong, it's actually quite a fair stage to play on male and female. I don't really think there was any discrimination or things against women. And of course, as my juniors now, a lot of them, more than half of them in my department are female. So of course, senior level, it's more male, but the junior ones are mostly female. And so we're also trying to give them more opportunities. And in fact, we're engaging them more into academia. So I think in consultant level, maybe as the time goes on more and more, you'll see more and more female. But academic surgery is actually a whole different field of difficulty and level, because you need to spend so much more time in grants, in publications, in conferences on top of your clinical duties. And a lot of female surgeons actually shy away from that. So we're trying to like engage them more in conferences, engage them in our studies to intrigue them on, you know, how interesting research is, and hope to bring talented female surgeons into academia instead of just doing clinical work. So Professor Vig, is it the same in the UK? Like for female surgeons going into academia, is it even less than, you know, in a consultant level?
So Shannon, I absolutely echo what you're saying. I think the younger generations coming through are finding a much fairer platform, and that's important. In the UK, we've got several ways of getting into academics. So our foundation year 1 and 2, so the first and second year of being a doctor, you can now do an academic component. So you do in a year, so a 12-month year, you do 4 months in academia, and that starts to build up your appetite, your excitement about doing academia, and then you can have surgical jobs that are half-time academia and half-time clinical. So and those actually are very well populated, male and female, now as we go through. Exactly as you described, Shannon, are, you know, we've got very senior academics. Majority are male, but we've got phenomenal women who are academics and professors in this country, you know, with huge research profiles. But your comment is so true. It's difficult when you're balancing. So in the conversation that you had of as you're rising up the ranks, you are supported. That actually, when you get to that glass ceiling and actually you suddenly become competition, actually it's really interesting how people behave. So women are often seen as the workers, the doers, the clinical, the on-calls, looking after, mentoring the junior trainees in the department, all of those conversations. But when it comes to this person needs to now be the lead and others, sometimes the doors close or just become a little bit harder to open. And so, Shannon, your conversation of, you know, you've got a wonderful department where they're actively supporting more junior members to develop leadership roles and become the future of the department. That's such a wonderful atmosphere to create. And I think our roles are to create that atmosphere. So academic surgery in the UK, it's still really tough. Women are less likely to do it. And the interesting thing, of course, is because of that, there's a gender pay disparity between men and women, because we have clinical excellence awards, and they are based on the work that you do, academic, research, education. And if women are less likely to do that, they are less likely to get those bonuses, and then we get a gender pay gap. So it's really important that we try and level out the playing field.
Moving on to that, in terms of to wrap up the discussion on mentorship and allyship. So Stella, in your role as a national leader, what are the 3 concrete behaviors you would expect from male colleagues who genuinely want to be allies to women in surgery, rather than just providing lip service?
Again, Lynette, what a great question. So first of all, if you haven't read it, I would ask you to read it's the report on sexual harassment in surgery, which was published by the Royal College of Surgeons, and the response to it, which was led by Baroness Kennedy. It is shocking to read. And so the first behavior I expect from male colleagues is the removal of what we call banter, which is mocking, intimidating behavior in the surgical theatre, on the surgical wards, not just dreadful behavior that you would not expect from someone who is a colleague at work. And so the first behavior I expect is that people call it out and actually deal with it if they're seeing that happening. And they should create, and that's the second thing for me. So one is they need to do something, they need to take action if they are there, and they need to role model the behavior that is professional, because we're professionals at work together. We are in the most intimate of spaces. You know, when you're around an operating table, you are so close together. Your personal space is invaded in a way that it isn't in any other aspect of our life. So the professional behavior has to be really important. The second is to ensure and create psychological safety and culture within a department so that you can go and talk to someone about anything. And that's not just sexual assault, discriminatory behavior, but it's when you're worried about a case where a case you've had a complication and you want to talk through it. Because if you can talk through a complication, as a group, you can learn from the complication and it's less likely to happen again. Otherwise, people start to hide complications and actually things then spiral and people leave surgery. And often they leave surgery because there's been a dreadful incident, which means that they are then struck off. Actually, if you go back 5-10 years, you can normally find something that you could have changed that would have supported that individual. So 1, take action. 2, create psychological safety and the culture. And 3 is the conversation of support and develop colleagues. It is really interesting how sometimes people expect, and it's male and female, but they expect them to be fully formed at the operating table as soon as they're there. And you have to give patience and you have to develop your trainees. I think when you're doing surgical selection, you choose trainees who show that they have the potential to be a fabulous surgeon. And the potential you can't change. They have it or not. Someone has a good pair of hands or not. But actually nurturing them, giving them patience, allowing them to fail sometimes, but picking them up and developing them, opening up doors to conferences and papers and new techniques, sending them across the world for a fellowship. Investing in your trainees becomes important. So take action, create the psychological safety, and make sure you mentor, support, and develop your trainees. I think those are the 3 things I would expect.
Thank you. Now, we would like to move on to the topic of education and training across borders. And I would like to put forward the next question to Shannon. So, Shannon, our season's theme is Global Surgery Meets Education, Asia at the Crossroads, and most of our episodes revolve around this theme. So, from your perspective in Hong Kong, what is the biggest educational gap facing surgical trainees in Asia today? And it can be from at a very young age, let's say from their schooling age to their medical school age to even postgraduate age. And how does it differ from what you see in Western training systems? I think one of the case in mind is that I really wanted to say it now is that even in Singapore, up to 2003, there used to be a quota in our medical school entry. When I was applying to be a medical student in National University of Singapore, I was rejected. And I had equally good CV as any other male surgeon, any other male medical student back in the early 2000s. Because I came from another country, so I'm not competing with the local citizens, as well as I was a female. It was pre-2003, so you can guess my age by now. So I was being offered the position of a pharmacist student. I rejected that offer and I continued to study in my university in Malaysia. But in the end, I'm here now in Singapore. So I mean, all's well that ends well. But this system has been so recent, up to even 2003 in Singapore. So when it comes from your perspective in Hong Kong, what do you think are the educational gaps or the systemic gaps facing our trainees today?
Oh, well, I would say in terms of the education gap for our young trainees, we don't really teach them formally how to handle stress and how to handle like the very long working hours as a surgeon, because like this is a very important and most difficult thing for females in terms of like physical ability and emotional ability to go through all these on calls, and also as you mentioned, the complications from surgery, because this can be very, very stressful. And we don't formally teach them. It's always like you just have to navigate your way through, right? If you're really stressed, you just find someone to talk about it, but there's no like formal way of teaching you how to handle stress. And in terms of into academia also, I think our in Hong Kong, we don't encourage them enough to go for clinician scientist, like the basic lab research and things, because even in medical student years, we do have the opportunity to take 1 year off for like an extra degree, but then no one does it. It's just like so not popular. People just want to graduate quickly and just be a doctor. And so when you lose that opportunity when you're a junior, so at a senior level, if you want to go back to that, it's actually more difficult to go back to do your research and lab stuff when you are like after your fellowship. So then it creates less academic surgeon in the long run. So I think probably that we need to encourage it at a very young and nurture it at a very junior level to get more people interested into becoming a clinician scientist, which I think is kind of the way to go nowadays. How about in Singapore and in Oman? Do you have a program for encouraging juniors into research?
Maybe let him go first.
Actually, more and more I see medical students in participating in research projects nowadays. So I have a lot of my students and my junior doctors who participating in research, which was not the case. In my residency program, of course, a research project was mandatory, and the same thing I was encouraged during my fellowship. During my medical school years, which was from 96 to 2003, I worked as a research assistant, which is I was paid by a part-time work. Actually, it was encouraged. So the students was encouraged to be with the professors in the university to be part of big researches. However, it was not mandatory. It's what up to you. So I remember during my medical student years, I participated in 2 projects as a research assistant at that time. In residency, you need to have at least 1 research project to pass the residency, and you are very well to present and to have a project during the fellowship as well. But I can see my medical students now also getting more involved with research. So I think as the time passes, more and more people they get involved in research in younger age.
Yes. As for Singapore, we are similar to in Oman. We also the first basic thing is that we ask the residents to have at least a research project a year, or a group project by the end of their training. That is the bare minimum. But what's more importantly is that because they build relationship and mentorship with their future faculty through their research project, when either a young medical student or a young trainee pre-entry into residency. So when we work with them and we see that these medical students or this medical officer, this SHO actually has the capability as well as the personality and the dedication to actually complete projects with us, And then we try to give them, entrust them with a, let's say, a higher level project, like a prospective study from a case series or prospective studies. And we say that actually these are the people who are actually can deliver, and they can actually be able to provide the right attitude, okay, to succeed in the difficult world of surgery. We actually try to be very vocal about them during the residency interview and their matching process, and this will usually bear very good fruit for them. So in that way, this is how we try to narrow the gap that we see from the other Western training systems, especially those with very much more established surgical residency programs.
So Hind, in ELSA Oman has been very active in bridging educational gaps across the region. So what is the innovative educational initiative you have launched in Oman that you believe that have scaled across Asia to empower women in surgery?
Actually, I thought of this question, and I couldn't think of anything more than passion to the work you have and the specialty you have. So I have this passion to my work, and I have and because of I'm very passionate to my work. I try to excel as much as I could to taking care of my patient, to learning new skills, and to do the maximum and to stay true to myself to take care of my patient. And I think this would have shown other female colleagues the interest that I have, and let them see me as a role model in my passion to my work. I couldn't see of any something very instrumental or something very physical as an innovation, but my passion to my work and being a role model to being passionate and to being true to myself. And for this, the girls probably see me this passionate, and they would like to be as passionate in their the area of their interest. I think that's the only thing.
Okay.
So going back to probably Stella, with your role overseeing elective care recovery in the NHS, you have a unique perspective on workforce training. How can training programs prepare surgeons, particularly women who may face career interruptions, to return to practice confidently and completely after long breaks or maternity leaves?
So let me answer that in two ways. Firstly, we've got the Women in Surgical Training, and that supports women. So there's huge amounts of mentorship on there, which comes from the Royal College of Surgeons of England, also Edinburgh, but also we've got Glasgow in Northern Ireland. And so there is a network of women that can do exactly as you described. You know, your role modeling will open doors for so many people and will give confidence to so many people. And we have that in England. We also have something that is called support. And that is if you are a person returning from any kind of break. So men coming back from research find themselves underconfident going back to the clinical space. But women coming back from maternity, we have a program that is set out so that you come back and make a decision of whether you want to come back full-time or less than full-time, how long you're going to be away in. It might be that if you're away for a year, in the last 3 months before you come back, you start coming in for what we call in-touch days. So you come back into theatre or go back into clinic and actually re-establish yourself on the shop floor, because it's hard when you've been out of work for such a long time to come back and do that. So there's a formal program. It's called Support. It's available to anyone. You can have a look at the way it's set up. But again, there are fantastic things happening across the world. And the conversation about workforce is really interesting. I'm giving talks at the minute and I'm being quite provocative and saying I don't need any surgeons of the future. Now, the reason I say that is because our healthcare system is changing. So if we think about, so in the UK, we now have, well, the world has obesity drugs, weight loss drugs. If you have weight loss drugs and actually we control the health of our population, actually you could get rid of symptoms of gallstones because we're no longer obese. Hip replacements, knee replacements, spinal surgery may not be needed in the same way. Bariatric surgery will certainly not be relevant. So actually the conversation is what is the future of surgery? Because, and then I have conversations that people say, well, that will never happen. Well, highly selective vagotomy used to be the thing that everyone used to do. No one has ever seen one. I've seen them, I'm old, but no one has ever seen them anymore because we've got the PPI drugs that support. So we've got genomics, we've got cancer vaccines coming through. Will cancer surgery be a thing in the future? So there are conversations of what does our workforce look like in the future. There is also the conversation that's coming through of how we deliver care. So as I said, I'm very old. I started med school in 1984 when I presume none of you are actually born, Lynette, even with you giving away your age. I think it's probably after 1984. So there's so 1984, I qualify. I'm now practicing now. The way that we deliver outpatient care, for example, has never changed. In our country, we have general practice, so we have primary care. Primary care refer to the hospital. We see the patient and we do whatever is necessary. But there are lots of patients coming who never need to come. So if you had, for example, in the vascular pathway, if you had general practice and you had really good vascular care practitioner nurses who manage claudication, who manage varicose vein in the community, advanced nurse practitioners who do varicose vein surgery under local anesthetic in an outpatient room, actually you don't need vascular surgeons to do what we are doing in the same way. 30–40% of my activity would go, and I would then concentrate on aortas, carotids, and lower limb bypass. But if we get our patients fitter, last year was the last year that a young person could buy a packet of cigarettes in the United Kingdom. So if the health of our nation improves, we will still need, and I'm talking now about, I'm calling them macro surgeons. If I go forward 15 years, my suggestion is we'll need macro surgeons who continue to look after the complex disease that we have now, because prevention hasn't hit. But we will have nanobots and we'll have robotic surgeons potentially doing tele-robotics. And we will have clinician scientists who work with genetics and algorithms and AI who will support our nation. So I think we're in a really interesting transformation stage. And anyone who is young on the call, and I include the three of you, there is a conversation in your lifetime, you will see that transition. My transition was from open surgery. I used to love a laparotomy where you didn't have a CT scan because they weren't available. And you went into the Pandora's box at 2 o'clock in the morning. You had a clinical decision of what you were going to find and you enjoyed sorting out the problem. But we've gone from open surgery to now having fantastic diagnostics, endovascular. We're now going laparoscopic and we're going into the world of robotics. And if you think about Star Trek, and I love Star Trek, if you think about Star Trek and the extracorporeal management of disease that's happening, these things are going. Who's looking at workforce development, we have to think about things in a radically different way to the way we are now. And they're the kind of things that we're beginning to grapple with. But of course, my current problem is, I have 7 million, well, I have 6.5 million people waiting for treatment in the United Kingdom, in England, and 80% of them are waiting for outpatient care. So we've got a problem now, but even with doing that, we still have to look to the future. But it's going to be so exciting. And I think surgeons are great leaders and they need to be at the forefront of this.
Indeed. Thank you, Prof. Vic, for giving us that excellent primer into the next discussion on policy, leadership, and advocacy. So, as you mentioned earlier, you sit at this very unique intersection of clinical surgery as well as the national health policy. So, what would you say is one policy change that you are currently championing in the NHS that, if successfully implemented, would create a more equitable environment for women in surgery? And what can surgeons in other countries learn from that effort?
So I think England has unique policy making. And I think, as you've demonstrated on the call today, there is fantastic policy and activity around the world. And I think we need to learn from each other internationally. I don't think there is any country that's unique that has just got it right. But I think there are elements of what we are all doing that works really well. I'm not sure there's a policy that I would say is making a real difference for women. The conversation about equality, about work, we know that if we look at our consultant workforce in our country, you know, back in 1991, we were doing 100+ hours a week, and I know many of you are still doing those hours. We are now in the UK restricted to 40 hours a week. There is a conversation that we may go down to 36.5 hours a week. That's really difficult for a surgeon. We do, you know, as soon as you've done a 3-session day and an on-call, the 36 hours have gone. So, you know, you're in work 2 days a week. And actually, surgeons tend to be people who want to do more. So you will fill your time with other things. So that's a tricky conversation that's happening in our country. But I think the one policy which is made up of many things at the moment is a complete reset of how we deliver healthcare. So at the minute we are a national health service, but actually we treat sickness. So you know, Shannon, with your general surgery, you know, the conversation, you know, Hind, you're on call, you are constantly dealing with complications of disease. What we are trying to do, and it's a 10-year health plan, what we're trying to do is reset this into a 10-year policy for prevention. And if we prevent disease, there are two things. One, we reduce burden of cost, because as soon as if I do an amputation, it costs our service 120,000 pounds. If actually we'd given the right cholesterol management, platelet management, stop smoking, exercise, actually you can reduce the risk of diabetes control. You can reduce the risk at the other end. So one is the conversation policy transformation into prevention rather than management of sickness. The other is to really diversify our workforce. And so at the moment, we have very dedicated blocks. So we have what we call primary care, which is front end. We have community care, and then we have secondary care, which is hospitals. What we are trying to do is to demedicalize pathways of care. So Shannon, you do upper GI. So Guy's and Thomas's hospital, which is opposite the Houses of Parliament, so very an important hospital. They have put dietitians and a psychologist at the front end. So when a GP refers in, a psychologist and dietitians will have a look at that referral. 50% of the patients are now not being seen by gastroenterologist or a surgeon because actually their problem is not a medical problem. It is related to stress or IBD, not inflammatory, but actually irritable bowel. And they're stress related. And if you can understand what is driving stress, change their diet. We have lots of allergies that are now coming through and food intolerances. They don't need a medical model of care. They need a model of care. So we're trying to unpack and, oh my gosh, and the other thing that I am desperate, well, we are desperately trying to do is to stop diagnostic tests happening in the way that we're doing them. I'm the senior responsible officer clinically for the diagnostic program, and we are spending billions on putting in new capacity, MRI scanners, CT scanners, everything in the world, endoscopy suites. We are doing so much endoscopy, we are not finding more cancers. So there is something about how do you triage to make sure the right patients get the endoscopy. No under 55 should really have an endoscopy unless absolutely warranted. There are conversations of how do we do demand optimization. And again, because I'm older, we didn't have the diagnostics. So we made clinical decisions based on clinical history taking and clinical examination. My younger colleagues coming through are holding clinical risk in a very different way, and therefore it's not uncommon just to do a diagnostic test. The question is the diagnostic test needed? And there is something about using our diagnostic tests in the right way, but actually not just using them because we have them in our armamentarium of in our toolkit. So the policy changes are prevention, different models of care. So we have neighborhood conversations coming in, and then the conversation of unpacking that medical model and making it a more multidisciplinary model that actually supports the patient and really empowers the patient. So I think, Shannon, those are the three things that are coming through.
So, Hind, as a leader in bariatric and metabolic surgery, a field often accompanied by social stigma, how do you advocate for your patients while simultaneously advocating for your own leadership role as a woman in Oman? And how do these two forms of advocacy intersect?
Very interesting. I'm very passionate about obesity. That's why I became a bariatric surgeon. So by continuously reading about obesity and by understanding that obesity is actually a disease, it's not a stigma, and believing it deeply myself, I became advocate for my patients and knowing also the community and how they think and how they would think of it as a stigma, I can respond to their questions. And so by being advocate for my patients, by understanding their disease, I became advocate for myself. By merely knowing and understanding about obesity, it's a disease, and I totally trust it. I totally believe it. And that's why I defend any patient who suffers from obesity.
Okay.
Okay. We go back to Prof. Vic. So traditionally, surgery is a male-dominated field in many parts of the world. And although the perception is changing all over, also with us, the perception is changing. Females are becoming more and more in surgery. Women occasionally first assumptions from patients and families about authority and suitability. What would you advise female surgeons to handle these situations? And what system level change help normalize women leadership in surgery?
Again, fabulous
Though it didn't
questions.
happen to me lately, but especially when I was younger, I had this assumption many times.
And it's so common, Hind. It's so common. Can I just do a shout out in the chat? Professor Nabila Talat, pediatric surgeon in Pakistan, in Lahore, is saying, and I love what she's written. She says, I have more than 50% female trainees, but a paradigm shift is underway as young female faculty members are now coming by selection on merit. that won't be happening on its own. And I just want to give a shout out to Nabila, because what a fantastic culture you will have developed. So well done on that. Hind, it's really frustrating, irritating, and it used to make me really angry that, it's not as if I looked like a young child, but I'd be on a ward round, with my white coat on, and then we didn't have white coats, but you'd be on a ward round with a male SHO registrar and a male SHO who looked like a child, and yet the patient would turn to them and say, Mr. So and so, what do we need to do? So and it is so common. It is just an assumption that's made. There's a joke that is often told in the UK of there's a parent rushes to hospital with so a child is injured and goes to hospital, and the medical team phone the parent. The parent rushes to hospital and says, "Where is my child? I'm the surgeon on call." And nobody knows who that person is because they're a female rather than a man. And they expected the male surgeon to arrive, not a female. And this is resonant across the world. So there are a few things I did, and then I'll talk about policy, but few things I did. I had a badge on, and I think it's really important because people will always make the assumptions. So I used to have a badge, which, well, I still have the badge, which says Stella Vig, consultant surgeon. And I think it's important that you claim that right for yourself. The second is, when that happens, don't be fearful of saying, "Thank you very much, but just to say I'm the consultant and I'll be leading your care," and introduce yourself again. In clinic, when the patient comes to see you, just make sure it's enforced who you are. And often you have to say it twice, because they will still come in and say, "Now can I see boss?" And you just have to say, "Well, actually, I'm going to be the person who's looking after your care." For women, it is also important how you dress. So men will often wear suits. So I'm not sure about the dress code in many countries, but in the UK, all the men used to wear suits, and the women could wear whatever they wanted. We have now come away from that. It's more likely to be scrubs now. So actually that creates some equality. Whereas before, a suit on a man was very different to a woman wearing a dress or wearing trousers and a top. So that policy change of dress code has actually started to make a difference. But the way that you dress also carries authority. Whether you wear really high heels, I used to wear very high heels because I am very short. I'm only 5'2". All the men I worked for, or with, were all about 6 foot. And so I was this tiny child that used to walk behind them. So I would wear very high heels to make sure that I was at the same height of them. But of course, then when you go into theatre, you put your clogs on and you just shrink to the height that you normally are. But I think there are subtle things that you can do. So there is something important, claiming your space and not being worried about claiming your space. That's hard to do when you first start. But once you start doing it, if you fake it until you make it conversation, if you start doing it, you will become more and more confident in doing it. And Lynette and Shannon, it'd be really good to hear what you are doing and how you do it as well. But the policy conversation, dress codes have made a difference. You are equals in scrubs. It's very hard to not be equal in scrubs. There is a conversation that everyone should wear a badge, so everyone's name is there. So I am consultant surgeon, but my SHOs are named as SHOs on their badges. They start to make a difference. The other thing we've started to do on certain wards is actually put out a hierarchy tree of who is who. So actually when patients and families come in, they can see that I'm Stella Vig, I'm the consultant on the ward, and actually I've got a team that work with me. So subtle things start to make differences. But could I ask the three of you how you manage that? Because I am sure you've encountered that conversation of they think a male younger person is the boss.
Will you start, Lynette?
It used to be like that. When just a few years ago, because I tend to look young, and a lot of us also of a smaller stature. So I think that is It's quite a common comment from my patients at times. But the point that I want to say is that the moment I speak up, I start with my voice in confidence, with the right cadence and with the right amount of information. Everybody just realize that, oh, this is the boss. So I think it's just not just your external appearance as well, but it's the demeanor and the charisma as well as the confidence that you have. The moment you appear and you talk to them, they may assume initially that, oh, you're the medical student, or are you the practitioner nurse? But the moment we start introducing ourselves, and that we don't, sometimes I will just realize that, okay, I always forget about what they say. Oh, are you the student, or are you the parent, or are you the friend? The moment I say that, hi, I'm Dr. Lynette Liu, and I'm taking care of you today, and I will just go on and just ignore whatever that they pursue me to. And then in the end, I stopped realizing that people are underestimating me, and I think that it's just something that we have learned to grow up from.
Yes, I totally agree, Lynette, because like as Asians especially, and we're quite small, and we tend to look very young. And especially if you stand in amongst our female trainees, you do like sometimes the patients can't see you, right? Because you're just like in the middle of like really tall men. And so when I do like a consultant round, my patient would ask me, so when is the doctor coming for rounds? And you'd feel like, okay, like how, like, I guess at that moment you feel that it's not an insult, but you feel really bad, but you just need to ignore it. And as you said, just reaffirm that I'm Dr. Shannon Chen, I'm the consultant, I'm the head of the upper GI team, and I will be like helping with you and managing your case from now onwards. And with that, they usually they would start with a different look on you and give you respect. And with the knowledge and the confidence, then they begin to realize, okay, this person knows what she's doing. And I guess it's a lot of communication. And I agree the dress code is important. So now most of our trainees wear scrubs, but I usually would try to wear formal, like not suits, but like formal with trousers and maybe a shirt, just to make sure that, okay, you stand out amongst the many scrubs, and so they know that you kind of a little bit different.
I think I do the same from the dress code point of view. And I've grown that fact as well. With time, I started to sound more in authority and more confident, and people would know. Plus, in Oman also, it is a small community. The population is small, and usually nowadays people would have Googled you and know you before they come. So in the recent years, I didn't have to face any of these issues.
Thank you. In the interest of time, I would like to ask this question before we wrap up to Stella. So I'd like to ask you about one piece of advice, or any advice that you would like to give to a young female surgeon in Asia who is considering to pursue leadership path alongside her clinical career. What would you tell her?
Richard Branson says, if someone offers you an opportunity, you need to take it. And I completely echo that. I can guarantee any young female, actually, most females watching this, what will have gone through their heads is, it's a wonderful job that's out there. There's a great opportunity, but I just can't do it, so I won't apply. If I'm operating in theatre and I leave my male registrar and female registrar at the table and I go to get a cup of coffee and come and sit in the little coffee room, I can promise you that my nurses will come and find me and tell me that I need to go back in to support the male registrar, who won't be asking for help, and tell me not to come when the female registrar phones and says, Miss Fig, can you come back into theatre? Because they're doing fine, but they want a little bit of extra support. So there is something that is built in, and it is Probably, and Asian, and I'm being very provocative, so please forgive me. But Asian females, we are taught from a very young age to be subservient. We respect hierarchy, male, and it depends on families, of course, but traditionally, male members of families are often lauded more than female parts of the family. Even if it's not in your family, it's inbuilt into our cultures. And so we are brought up to be slightly underconfident. So my conversation with any woman on this call, it doesn't matter how old or young you are, is three things. One is if someone offers you an opportunity, just take it. Doesn't matter whether you can do it or not. Have a go and do it, because they won't have asked you if they didn't think you could. People don't ask you to help you fail. Really unusual to do that. The second is surround yourself by colleagues that you trust. Shannon, you said earlier, I think it was yourself who said, you need to have people that you can be really comfortable talking to from the deepest part of your heart to say, I'm struggling here, this is stressful, or I'm just not sure whether, I can do this, or there isn't enough time, what shall I do here? And you need people around you that will give you honest feedback, but will support your decisions and actually push you upwards and push you to climb rather than just stay where you are. So continue to give that challenge. And you need a group of friends. It doesn't matter whether they're male or female, that's important. And the third is aspire to excellence and success. Again, for female surgeons, there is a conversation of, I'm going to get my consultant job, and actually, that's the pinnacle of my career. I can promise you, when you get to your consultant job, it's the start of your career. I'm nearly 60. I'm sure I've got quite a few years to go. There's a whole life once you start your consultant career that goes forward. But I think what's important, and I think Lynette, you were talking to this, well, I think everyone has talked to this, is the conversation of what you do at medical school, what you do through your career journey as a trainee matters when you get to a consultant. So take on small roles, rota management, leading the clinic, the clinical teaching as a medical student or as a resident. Your conversation, Lynette, of ensuring that you produce papers and you get involved in research collaboratives. We say that our registrar should have at least 2 papers a year. But all these things start to build in, and taking small leadership roles as a medical student, as a resident trainee, and then doing the same as you start through your consultant career, it starts to really support that portfolio. And when you then turn around and apply for a job, the answer is not, I would like to do this job because this is my first step into leadership or management. It is, I am a female surgeon. I am compassionate. I am kind. I look after my team. I have shown my success in leadership positions to date, and I want this job. And I promise everyone on the call that they can.
Thank you. So I would like to end this this dialogue with a question for each of you. So if there is fresh medical graduate today who is watching this episode, might be not yet in the world of surgery, still studying, still undifferentiated, but one day dream of becoming a surgeon. So it could be male or female. And people tell her that her family or teachers or community tell her that surgery is not for you, especially in women in certain parts of the world. What is the one sentence that you will say just to make her rethink and make this person who is young and who's thinking about their future, that will possibly make her change her mind and build that confidence and resilience? Maybe I'll start with Shannon.
I think I would tell her, trust yourself. So you are the one person who knows yourself the most and who knows that you can do whatever you put your mind to. So trust yourself and trust your instincts, and go for what you really think you like. As long as you like your job, you have the passion, you'll succeed and overcome all obstacles.
Hin?
I think I would do the same. And I have some younger nieces who actually ask me the same. It's you should try. You should go and be in the field yourself and try it. And it's not wrong to ask a lot of people who have experience and find out if you want to do that. It's totally your life, and you are free to decide what you want to do.
Stella?
Yeah, no, to echo both of those. And I think um, if you're listening to this and thinking about whether you want to do it, the first question you have to really ask yourself is, do you really want to do it? It's not about the title. It's not about the title of being a surgeon. Do you really want to look after patients at the most vulnerable times of their lives? You will be trusted with their bodies. No one else is allowed to cut into a patient in the way that we do, but you can fix them and you can bring them. And sometimes you fix them and you get them better for the rest of their lives, and other times you manage their disease, but you are with them along that way. If that excites you and that's what you want to do, then just don't even question whether you want to be a surgeon. Just write it down on a piece of paper. I am going to be a surgeon. Put it away somewhere safe and look at it in 15 years' time. But hinge your conversation of go and find people to shadow, go and find people to go into the operating theatre and see if you really want to do it. But if you want to do it, you can. The world has changed. If people are not doing surgery because they still feel that they can't do it, it means my career in surgery, which I have absolutely enjoyed, has not achieved what I want it to do, which is to have an equal world for surgeons that anyone who wants to do it can.
Thank you. Well, as for me, I've truly learned a lot from this session, and I've been so inspired, and I've really have a really transformative insight into so many aspects of leadership, surgery, and being able to translate our resilience into our daily living, be it in the workplace or at home, maintaining the harmony in all that we do. So I just wish for all our listeners out there that may each of us, whether male or female, we find our ikigai. So I really love this concept. I've shared it before. And this Japanese concept of ikigai means a reason for being. If we discover what we love, what we are good at, what the world needs, and what we are paid for, if we discover our ikigai, and to many of us, our ikigai is surgery, right? If we find our ikigai, we'll find the ways and the means to make every day a happy and a harmonious day. I'd like to thank all of you, and maybe we will pass the time to Shannon for you to give our directions and your wishes for the future.
So actually in the chat group, you would see a lot of comments from people who are on the channel, including as Professor Vic has a shout out to Professor Nabila, and also a few other surgeons who have commented in the chat group. And you see that in fact the community is growing, women in surgery, and that a lot of people are aware that this is an important topic, and empowering women in surgery is becoming more and more important nowadays. So it's a very rewarding trend to see, and hope that by the time 10 to 20 years later, we would definitely achieve equality in surgery between the two genders.
Yes, indeed. So I'd like to close
even the network thinks that it's time to close the session.
Passing time now back to Dr. Sajid.
I think that was one of the wonderful
any,
TV episodes
housekeeping?
I have conducted so far. Thank you for all wonderful women across the globe being here. I really enjoyed it thoroughly. Behind the scene, I was really sitting and then seeing myself in my paternal role. What exactly? My wife is a doctor, Miss Wig, no, Lynette, no, I think him, no, as well. And then like how you work collaboratively. The moment Miss Wig said about like when you are exactly standing under the door and you're dropping the kid and second partner is going and coming, the way you have done the training and stuff. Thank you so much, everyone. I will just show in the end about the, for the sake of the audience, I won't take longer time, just last 1 minute maybe. If you can see can you see my screen?
We can see it, Sajid.
These are the ELSA projects we are conducting so far. This is the team, the big ELSA executive committee, from president to our administrators, our board and our Congress committee. What we are doing is, as we were talking about the ELSA, we have our own textbook of surgery, fellowship program, journal of surgery. We have ELSA ICC project, which are going on at the moment. We have an ELSA app, society YouTube channel, along with Facebook page, Twitter, LinkedIn, all the social media platforms. And we have this ELSA TV channel as well. And then moving forward, we have this VR library as well, which we set up in 2021 for the last 4 years. And we have ongoing projects, ELSA E-Academy, which does involve the webinar, the educational activities and everything. Our next episode in April, stay tuned. We'll keep on updating you through the ELSA app as well as onto the various platforms, including our ELSA even next year, which would be in Hue City in Vietnam. And these are the QR codes for the ELSA app and all the project. If you scan it, we'll share it later on. Thank you so much.
Thank you so much. Thank you for inviting us.
Thank you.
Have a good
Thank you.
day.
Thank you.
Thank you so much.
Bye.
Thank you.
Thank you,
Let me
everybody.
just
Thanks a
stop the
lot.
recording. Thank you, Prof. Lamando is